Dr. Padda, I'm aware of time. We're going to wrap this up soon, but can we very quickly talk about your perspective on cholesterol? Because if you're putting your, at least in the initial period, if you're putting your patients on a zero carbohydrate diet, so zero carbohydrate basically means
low,
no
very
fat,
low.
no vegetables. They're eating meat, they're eating protein and fats.
Yeah.
What happens to their cholesterol, and what happens specifically to the LDL, which is what most doctors these days are worried about? So
let's step back one step. Unless you have familial hypercholesterolemia, it's really not an issue. That's the reality. Now, if you have familial hypercholesterolemia, it's a different story. And certainly we would use medications to address that familial hypercholesterolemia. But the reality is that most patients have issues with cholesterol, not because of the cholesterol itself, but because of the inflammatory milieu that they exist in. The cholesterol you should think of is a Band-Aid. It's the ambulance running to the site of an injury to seal it up. And so just because you have high cholesterol doesn't mean that you have disease. It just means that you have high cholesterol. There's a lot of patients with very, very high cholesterol that do not have familial hypercholesterolemia that don't have any issue. And in fact, if you look at patients in their 60s, mid 60s, upper 60s, upper 50s even, and you put them on statins, which is cholesterol lowering agents, their morbidity mortality may actually go up on cholesterol lowering agents. So you need cholesterol to make hormones. And without healthy cholesterol, you got a problem. Now, the problem, there's one other issue here. It's not all cholesterol that's really bad. See, the thing is that what most people measure is LDL-C, and it's low density lipoprotein C. That's not bad cholesterol. The bad cholesterol is LDL-P. It's particle count. It's the small cholesterol. And most people never measure LDL-P. We do in our clinic. I have a lot of patients with very high LDL-Cs, but normal LDL-Ps. And then I have rare patients that have very high LDL-Ps, but normal LDL-Cs. And so it's the LDL-P that I'm concerned about. And that's what I get excited about, because that's the patient that I have to worry about. But if you lower their carbohydrates and you've lowered their leptin and their insulin, and you've improved the fluidity of their cell layer, of their bilayer, they're not going to get thrombosis, and their inflammatory load goes down, and they're going to do better. And so that's the gist of the long term. You do see some triglyceride increasing at first, especially if you enter fasting, because your body is lysing fat. And when it lyses fat, it turns it into triglyceride, and you get free fatty acids floating around. That's what it's supposed to do. That's not unhealthy. That's just your food system that you're feeding all your other cells, and it gets consumed. It only becomes a problem if it accumulates and it stays there. And so that, from my perspective, it's something that's manageable.
Mm-hmm. And do you look at, do you assess their insulin resistance by the ratio of triglycerides to HDL?
What we do is something called lipoprotein insulin resistance, LPIR. We certainly do triglyceride to LDL-C, but I find that LPIR is a more accurate measure. We also look at insulin level to glucose, and we derive a HOMO-IR, but LPIR is much more accurate. And there's a variety of ways to get to the same result, but I want to know what somebody's insulin resistance is. We don't do Kraft testing on people. Kraft testing is where you measure serial glucose levels against serial insulin levels over time. We don't have the capacity or time to do that. So that's why we do the LPIR and HOMO-IR. And it's a single stick rather than 3 hours of repetitive blood draws. Although that would probably be more accurate. But we still get sufficient information. And also I'm trying to identify, how much insulin are you actually producing, especially if you're morbidly obese and you're diabetic. How much insulin are you actually producing? So we measure C-peptide, and that gives me a real good idea of what their underlying production is, especially if you're giving them exogenous insulin. If they're type 2 diabetic and you're giving them exogenous insulin, you don't know how much they're producing on their own. And so you want to know what their C-peptide is underneath that.
I've always wondered how they measure insulin resistance in a type 1.
LPIR is possible, I guess, but I think you're going to be, it depends on what your weight stasis is. And so it's going to be a lot tougher to measure. But if you do like basically a clamp test and you're trying to maintain homeostasis, but it'd be way more complicated. I think the general gist of it is, are you, as long as you're not going into diabetic ketoacidosis, and you're decent weight, you're not morbidly obese, and you're using the least amount of insulin as possible, that would make you relatively insulin sensitive. It's not going to give you a numeric number, but it's going to give you a relative feel of what that is. Now, you probably get to a numeric number by other means.
Yeah. And as long as your insulin sort of dose isn't, or requirement isn't going up consistently.
Isn't going up. And you also have to realize that the pancreas is not the only place that makes insulin in the human body. You get peripheral insulin production as well. And it's in other cells, but it's a very small portion of it. But there is some peripheral insulin production, but it's not in beta cell. But there are some other compounds that are insulinogenic that you get. So, but again, in a type 1 diabetic, it's much more complicated. And type 1 diabetics doing ketosis is much more challenging. It definitely, you can quickly, they're much more brittle, and you can get yourself into trouble if you're not well equipped to handle the type 1 diabetic. And I've seen some disasters happen where people do it on their own, and they're not sure exactly what they're doing, and they end up on the wrong end of it because they don't understand that just because you're in ketosis doesn't mean you're healthy if your ketones are 10, if you're a type 1 diabetic. And I've never, it's a little bit different.